Hello, today I'm going to talk about endodontic mishaps and procedural errors, especially about root perforations. So, root perforation results in a communication between the root canal walls and the periodontal space, the external tooth surface. The etiology of root perforations are iatrogenic perforation that occurs due to lack of knowledge about the internal anatomy of the tooth structure. It can occur at any level of the endodontic treatment. It could end in a zip or a strip or a furcation perforation, or its aftermath, as an example, the post-preparation perforation. While sometimes it could happen non-iatrogenic, especially due to internal or external resorption, trauma, and caries that affect the furcation area. And they could be classified according to the time of the perforation. It could be an old perforation or a fresh perforation. And when having a more recent perforation, it could lead to a better prognosis. And it could be based on size, large perforation or a small perforation. And especially when we have a perforation that is less than a 20K file size, it could lead to more better prognosis. And it could be classified based on the location of the perforation. It could be in the crestal zone or the coronal zone or apically. We could diagnose a perforation by using a radiograph, for example, taking a CBCT or taking two radiographic views and using the slope technique to know where is the perforation is. And we could see a sudden bleeding or pain during the instrumentation of the root canals or post placement. We could use the electronic apex locator, and we will notice that the apex locator will reach the apex on the machine while the file is not reaching to the full working length. Or we can simply see the perforation when we are using the operating microscope. We could manage the perforation either non-surgical or surgical approach. For the non-surgical approach, we could simply use MTA and biodentine as they are considered the best material for perforation repair. We could simply pack them and seal the perforation, and they could also induce the formation of cementum-like tissue. And for the surgical approach, we could surgically access the site of perforation, and especially done in cases of large perforation or perforations as a result of root resorption. And our last treatment of choice is intentional replantation. It is specially considered when orthograde and surgical treatment are not possible. It is indicated when perforation is too large for repair and inaccessible without excessive bone removal, especially in the lower mandibular molar area. When is the best time to repair the perforation? Immediately or delay the repair? Well, it's best to repair the perforation immediately, because when we delay the perforation, it can cause the breakdown of the periodontium, resulting in endoperiolesion lesions that are difficult to manage, and elimination of microbial contamination of the defect and sealing it properly is critical to success. What are the factors that may affect our success? First of all, the presence of a preoperative lesion, the sealing capability of the material, the perf size and location, our time of treatment, and the operator experience. The material that should be used must have a good physio, chemical and biological properties, proper sealing capacity, it should be antimicrobial, and have an osteogenic potential. The best two materials that could be used are MTA and biodentin. The most important predictor of prognosis is the status of the tooth prior to the perforation. For example, if we have a healthy, vital pulp prior to the root perforation, that means that we will have a much better prognosis in the future. While if we have a periapical radiolucency or an apical lesion prior to the perforation, that means that we will have a much worse prognosis in the future. The second most important prognostic factor is the location of the perforation. The perforation should be compared to the level of the crystal bone and not to the location of the perforation along the root itself. So for example, if we can see here in the diagram, distally the critical crystal zone in the distal root is located in the middle third of the root, while mesially the critical crystal zone is found in the coronal third of the root. So, for a good prognosis, we should have a vital pulp, small and recent perforation. It should be treated and sealed by an MTA or biodentin, and it should be apical or coronal to the crystal bone level. As we can see in this diagram, here is the crystal bone level and the perforation is apical to the crystal bone level. And it is at the middle third of the root if we are comparing it to the root surface. While on the worse prognosis side, if we have a necrotic pulp or a periapical radiolucency prior to the perforation, large or an old perforation, and we are repairing it by any other material, and it is at the crystal bone level. For example, in this diagram, we can see that the crystal bone is approximately at the middle third of the root, and our perforation is exactly at the crystal bone level, which is again in the middle third of the root as the previous case. But in this case, it will be a much worse prognosis, while in the last case, it is a much better prognosis. So the level of the perforation according to the root surface, it is the same. It's at the middle third of the root. And the most important factor is the crystal bone level. To read more about this subject, I recommend you to read Cohen's Pathways of the Pulp, Chapter 8, and two other articles. The first one is by Fuss et al. In 1996, and the second one is by Carlos Estrella in 2018.